The Norwegian steamship Bergensfjord limped into Philadelphia harbor on a grey October morning in 1918. Carrying more than passengers, it carried death incarnate. Within hours of docking, the invisible killer began its work. By nightfall, healthy dock workers were collapsing with fevers that burned like furnaces. By the end of the week, bodies were stacking like cordwood in makeshift morgues across the city of brotherly love. The Spanish flu had arrived in America, and it would claim 675,000 American lives before its hunger was finally satisfied. But here's the question that should haunt every one of us, as we remember our own recent brush with pandemic catastrophe during COVID-19. What if that ghost ship had docked in 2025 instead of 1918? What if those doomed passengers had stepped onto American soil armed with the medical arsenal we've built over the last century? The vaccines that saved millions during COVID-19, the ventilators that kept our loved ones breathing, the antibiotics that turned death sentences into minor inconveniences. The answer isn't just academic. It's a survival blueprint written in the blood of 50 million souls worldwide. A roadmap that could determine whether the next pandemic kills millions or thousands. Whether our cities shut down for years or adapt and thrive. Whether we finally break the cycle of pandemic devastation that has haunted human civilization since the dawn of time. The Spanish flu was a monster unlike anything the world had seen. Unlike seasonal influenza that typically killed the very young and very old, this biological terrorist had a particular appetite for healthy adults in the prime of life. 25-year-olds went to work in the morning and were dead by evening. Entire families vanished in the span of weeks. In Philadelphia, the death toll climbed so high that steam shovels dug mass graves in Potter's Field. The city that had given birth to American democracy was brought to its knees by an enemy it couldn't see, understand, or fight. Picture Dr. Sarah McKinnon, a fictional but representative physician at Philadelphia General Hospital during those terrible autumn weeks of 1918. Educated at the finest medical schools, trained in the latest techniques, she found herself completely helpless as wave after wave of dying patients flooded her wards. She had no idea what was killing them. Medical professionals didn't even know that influenza was caused by a virus yet. They were convinced they were battling Pfeiffer's bacillus, a bacterial culprit that would later prove to be merely a bystander to the real massacre. Dr. McKinnon had no diagnostic tests, no treatments, no understanding of how the disease spread. She watched young mothers die gasping for air while their babies cried in the next bed. She saw robust dock workers turn blue as their lungs filled with bloody fluid. She witnessed entire hospital wards fall silent as death claimed every patient within days. All she could offer was cool cloths, aspirin, and prayer, medieval remedies against a 20th century apocalypse. The diagnostic darkness of 1918 was absolute. Imagine trying to fight World War I with Civil War maps. That's essentially what American medicine was doing. The average time to identify the causative agent of the Spanish flu was measured not in hours or days, but in months and years. Some researchers didn't conclusively identify the culprit until decades later. Dr. McKinnon and her colleagues were fighting blind against an invisible enemy that was always 3 steps ahead. Fast forward to January 31st, 2020, when the first COVID-19 case arrived at Providence Regional Medical Center in Everett, Washington. The contrast was staggering. Within days, not months, American scientists had sequenced the entire SARS-CoV-2 genome, developed PCR tests for rapid diagnosis, and shared genetic data with researchers around the world in real time. What took the 1918 medical establishment years to accomplish, COVID-19 researchers achieved in hours. But even our COVID-19 response revealed gaps that the Spanish flu would have brutally exploited. Remember those early testing shortages when Americans waited days for results? The confusion about whether the virus spread through surfaces or air? The months it took to understand that simple cloth masks could save lives. These delays, measured in weeks during COVID-19, would have been measured in years during the Spanish flu era, with catastrophic consequences. Today's pathogen detection capabilities represent a quantum leap beyond even our impressive COVID-19 response. Metagenomic next-generation sequencing can now identify any pathogen, bacterial, viral, fungal or parasitic, in a single test without knowing what we're looking for. Real-time computational analysis can characterize a completely novel pathogen in 6 hours from sample collection to identification. CRISPR-based diagnostic technologies offer portable testing that could be deployed to every major port, train station, and airport, creating an early warning network that simply didn't exist when the Bergensfjord arrived in Philadelphia. If Dr. McKinnon had possessed 2025's diagnostic capabilities, she could have identified the Spanish flu virus within hours of the first patient's arrival, sequenced its genome, determined its transmission characteristics, and shared that information with medical centers across America and around the world. Instead of fighting blind for months, American medicine could have mounted a coordinated response from day one. But identification was only the beginning of 1918's medical nightmare. Here's the shocking truth that took scientists nearly a century to understand. The Spanish flu virus itself rarely killed people directly. Instead, research reveals that up to 95% of deaths were caused by secondary bacterial pneumonia. The virus was essentially a biological saboteur. It infiltrated American lungs, weakened immune defenses, and damaged respiratory tissue, creating perfect conditions for bacteria that normally lived harmlessly in people's throats to become lethal invaders. Dr. McKinnon would have seen this bacterial carnage firsthand. Patients would arrive with typical flu symptoms, fever, aches, cough, but within days, their conditions would deteriorate rapidly as Streptococcus pneumonia, Haemophilus influenzae, Staphylococcus aureus, and Streptococcus pyogenes mounted secondary attacks on virus-weakened lungs. These weren't exotic foreign pathogens, they were everyday American bacteria that turned deadly when viral infection opened the gates. The bacterial distribution across American military camps during autumn 1918 told a devastating story. Among pneumonia patients at 21 U.S. Army camps, S. pneumonia predominated at 12 camps, H. influenzae dominated at 6 camps, and Streptococcus species ruled at 3 camps. At Camp Devens outside Boston, young soldiers who seemed healthy in the morning were dead by nightfall, not from the flu virus, but from bacterial pneumonia that their damaged lungs couldn't fight. Camp Jackson in South Carolina and Camp Syracuse in New York saw massive outbreaks of deadly S. aureus pneumonia. Dr. McKinnon had no weapons against these bacterial invaders. Alexander Fleming wouldn't discover penicillin until 1928, a decade too late for the 675,000 Americans who died. She could only watch helplessly as secondary infections claimed patient after patient. Bacteria that modern emergency rooms treat routinely with simple antibiotics were death sentences in 1918. During COVID-19, we learned that secondary bacterial infection remained a complication, with almost 1 in 4 severe cases developing bacterial co-infections. But the crucial difference was that we had antibiotics. Streptococcus pneumoniae was still the most common secondary pathogen, just as in 1918, but American hospitals successfully treated most cases with targeted antibiotics and advanced critical care. What was a death sentence in 1918 became a manageable complication in 2020. Today's antibiotic arsenal would have been revolutionary in Dr. McKinnon's hands. Broad-spectrum empirical therapy available within hours of hospital admission, rapid bacterial identification using modern culture and molecular methods, targeted therapy based on antimicrobial susceptibility testing, IV antibiotics for severe pneumonia and sepsis, tools that could have prevented 70 to 90% of bacterial pneumonia deaths in 1918. For the United States alone, that translates to 470,000 to 600,000 lives saved from bacterial co-infections, nearly 90% of our total 1918 death toll. But even antibiotics couldn't save everyone. When Dr. McKinnon's patients reached complete respiratory failure, when their lungs filled with fluid and they couldn't breathe, she could only watch them suffocate. There were no intensive care units, no mechanical ventilators, no oxygen therapy beyond crude methods. The iron lung wouldn't be invented until 1928, and modern mechanical ventilation was still decades away. Picture the scene at Philadelphia General Hospital in October 1918. Wards filled with young Americans turning blue as their lungs failed, gasping for air that wouldn't come, while physicians trained at Harvard and Johns Hopkins stood by powerless. Our recent COVID-19 experience gave Americans a crash course in the life-saving power of mechanical ventilation. We watched as ICUs from Seattle to Miami filled with ventilators, as governors fought over ventilator supplies, as manufacturers retooled production lines to build these machines. We learned that vaccination reduced the need for intensive care. But for those who did require it, mechanical ventilation meant the difference between life and death. Nearly 1 in 4 patients admitted to ICUs with COVID-19 required respiratory support, yet survival rates were dramatically higher than any previous respiratory pandemic. Modern American critical care would have transformed Dr. McKinnon's helpless vigil into active, life-saving intervention. Today's ICU ventilators provide complete respiratory support, with volume-controlled ventilation, pressure-controlled ventilation, and synchronized intermittent mandatory ventilation. For the most severe cases, ECMO, extracorporeal membrane oxygenation, essentially provides artificial lungs. Advanced monitoring gives real-time blood gas analysis and lung function assessment, while specialized protocols prevent ventilator-associated pneumonia. Studies from American medical centers show that mechanical ventilation can reduce mortality from respiratory failure by 60 to 80% compared to supportive care alone. During COVID-19, American ICUs achieved survival rates above 70%, even for the sickest patients requiring ventilation, a medical miracle by 1918 standards. If modern respiratory support had been available to Dr. McKinnon, an estimated 120,000 to 240,000 Americans with severe respiratory failure could have survived. The prevention void of 1918 was as absolute as its treatment failures. The Spanish flu caught America completely off guard. Information traveled at the speed of telegrams and newspaper delivery. Contact tracing was done with pen, paper, and shoe leather detective work. Quarantine meant locking people in rooms without medical support, food delivery, or basic communication. There were no vaccines against influenza anywhere in the country, no antiviral medications in any American pharmacy, no rapid diagnostic tests in any laboratory, no coordinated federal public health response. The federal government had no centralized role in pandemic response. The CDC wouldn't exist until 1946. Cities like Philadelphia ignored warnings and held massive parades that became super spreader events. St. Louis implemented early social distancing and fared better, but there was no national coordination, no federal stockpiles, no unified guidance. Dr. McKinnon and her colleagues were fighting not just medical ignorance, but institutional chaos. COVID-19 gave Americans a brutal but invaluable education in modern pandemic response. Operation Warp Speed delivered mRNA vaccines in 11 months versus the typical 10-15 years. Emergency use authorizations created rapid regulatory pathways. Real-time genomic surveillance tracked viral mutations as they emerged. Federal coordination provided CDC guidance, federal supply chains, and national messaging. We learned what works and what doesn't in pandemic prevention. Drawing lessons from both 1918's failures and COVID-19's mixed success, 2025's pandemic prevention capabilities represent a quantum leap forward. mRNA vaccine platforms can now design and manufacture vaccines in 100 days. Distributed manufacturing provides multiple production sites across North America. Modern antiviral drugs, oseltamivir, baloxavir, zanamivir, peramivir, can reduce symptom duration and prevent complications when started within 2 days of symptom onset. Digital contact tracing apps provide exposure notification. Genomic surveillance networks track viral evolution in real time. Perhaps most remarkably, existing pneumococcal vaccines could have dramatically reduced 1918's death toll even before Spanish flu-specific vaccines were developed. Children receiving pneumococcal conjugate vaccine show a 45% reduction in hospitalization rates for influenza-related pneumonia. Since 95% of 1918 deaths were from bacterial pneumonia, this existing intervention could have saved hundreds of thousands of American lives. The closest real-world test of modern medicine against pandemic influenza came with 2009's H1N1 swine flu, but COVID-19 provided the ultimate stress test of American pandemic preparedness. The contrast across 3 American pandemics is stark. The 1918 Spanish flu killed about 675,000 Americans from a population of 103 million, a death rate of 0.65%. The 2009 H1N1 pandemic killed about 12,469 Americans from 307 million, a death rate of 0.04%. COVID-19 killed over 1.1 million Americans from 331 million, still a death rate of only 0.33%, half that of 1918, despite affecting a much larger, older, and more vulnerable population. Secondary bacterial infection remained important during COVID-19, with almost 1 in 4 severe cases developing co-infections. But American hospitals successfully treated most cases. The real revelation came in ICUs. Vaccination was associated with reduced resource utilization, even when it did not prevent infection entirely. Even imperfect interventions saved lives at massive scale. Yet COVID-19 also revealed vulnerabilities that the Spanish flu would brutally exploit. Healthcare worker shortages, supply chain failures, regional disparities in hospital capacity, political polarization turning public health measures into partisan battles. These modern challenges didn't exist in 1918's more deferential society, but could amplify a pandemic's impact today. Even more concerning, the misuse of antibiotics has created dangerous resistance patterns. According to CDC data from COVID-19's first year, detection rates of carbapenem-resistant organisms skyrocketed. Acinetobacter increased 78%, Enterobacterales increased 35%, antifungal-resistant Candida increased 26%. The bacteria that caused secondary infections in 1918 are now often resistant to first-line antibiotics in American hospitals. Modern pandemic threats also move faster than their 1918 predecessors. The Spanish flu took months to spread from the East Coast to the West Coast, traveling by ship and train. Today, a pandemic virus would reach every major American city within days via air travel, spreading through transportation hubs faster than public health systems could respond. Despite these new vulnerabilities, a conservative analysis suggests that modern medicine could prevent 85 to 95% of a 1918-level pandemic's American death toll. Antibiotic treatment could save 330,000 to 540,000 lives by preventing bacterial pneumonia. Mechanical ventilation and critical care could save 120,000 to 240,000 lives from respiratory failure. Antiviral treatment could save 30,000 to 75,000 lives through early intervention. Rapid vaccine development could save 200,000 to 400,000 lives, assuming a 6-month timeline. Enhanced public health measures could save another 50,000 to 135,000 lives. Total potential American lives saved 730,000 to 1.39 million lives, essentially preventing almost all 1918 deaths. But the sobering comparison remains. COVID-19, despite all our medical capabilities, still killed over 1 million Americans. This occurred with multiple effective vaccines, several antiviral treatments, advanced critical care, and 3 years of accumulated medical knowledge. Pandemics aren't just medical challenges, they're social, economic, and political crises, requiring coordinated responses across all aspects of society. Imagine that Norwegian steamship arriving in Philadelphia Harbor today instead of 1918. Within hours, port health screening would identify sick passengers. Samples would be rushed to laboratories for sequencing and characterization within 6 hours. Results would be shared with the CDC, WHO, and state health departments. Rapid response teams would deploy. Contact tracing would begin. Antiviral prophylaxis would start for close contacts. Hospital systems would activate surge planning. Public messaging would flow through multiple channels. International coordination would prevent global spread. Within weeks, mRNA vaccine development would begin. Existing antivirals would deploy to affected areas. Hospital surge capacity would activate. Supply chains would secure critical medications. Manufacturing would scale for broader distribution. Instead of the 675,000 Americans who died in between 1918 and 1920, we might lose 50,000 to 100,000 in the first wave, Still heartbreaking, but representing a 90% reduction in mortality. The ghost ship is coming. Not that specific Norwegian steamer, but its modern equivalent, a novel pandemic pathogen combining 1918-level transmissibility and virulence with 21st-century global connectivity. Influenza viruses continue evolving in unpredictable ways. The 1918 virus acquired efficient human-to-human transmission through mechanisms we still don't fully understand. Current H5N1 bird flu viruses or other emerging threats might be developing similar capabilities right now. Americans who lived through COVID-19 have a unique responsibility. We've experienced pandemic fear, grief, and hope. We know modern medicine can turn civilization-threatening pandemics into manageable challenges, but only with proper implementation. We've learned that medical miracles only work if Americans trust them, use them, and support the systems that deliver them. We owe something sacred to those 675,000 Americans who died in 1918, to the million Americans who died from COVID-19, and to the millions who might die in the next pandemic if we fail to prepare. We owe them the commitment to build systems that make such death tolls impossible. We owe them the wisdom to learn from our mistakes. We owe them the resolve to invest in preparedness, even when threats seem distant. We owe them the unity to respond effectively when crisis strikes. The choice before us is stark and immediate. We can choose to learn from 1918's medical failures and COVID-19's implementation challenges, building systems that protect American lives when the next pandemic emerges. Or we can ignore the warnings, cut preparedness funding, and repeat the mistakes that cost hundreds of thousands of American lives. Every time we walk through Philadelphia's streets today, past Independence Hall where America was founded, we should remember that those same streets once ran with pandemic death. Bodies stacked in warehouses, families buried in mass graves, a city that helped birth American democracy brought to its knees by invisible enemies. That tragedy teaches us that American strength means nothing if we're not prepared to use it effectively when crisis strikes. The Norwegian steamship Bergensfjord represents every pandemic threat that has ever faced humanity. Invisible, inevitable, and potentially catastrophic. But it also represents our capacity to learn, adapt, and overcome. The Spanish flu taught us that nature can unleash biological threats that humble the mightiest civilizations. COVID-19 taught us that human knowledge and cooperation can overcome novel threats when we work together effectively. The next pandemic will test whether we've learned enough from both experiences to protect the lives that previous generations couldn't save. Will we have learned enough from 1918's medical failures and COVID-19's implementation challenges to respond with the speed, effectiveness, and unity that American lives deserve? The answer will be written in the lives saved or lost, the communities protected or devastated, the future secured or squandered. History will judge us by how many Americans are still alive after the next pandemic passes. The ghost ship is coming. Let's be ready for it. The 50 million who died worldwide in 1918, including 675,000 Americans, left us a message written in tragedy. Preparation saves lives, medical advancement saves lives, and coordinated response saves lives. We have the tools, we have the knowledge, we have been tested and taught. The only question is whether we'll have the wisdom and courage to act on those lessons when the next ghost ship appears on our horizon.